Hi, thank you. I feel like I should tell everybody to move to the front row here. I thought things were big in Texas, but this is so it is an honor to be here at HIMSS. This is my fourth one in a row, but first time speaking, and so it's exciting. We're going to talk today about a specific use case related to ER, post-ER use of telehealth. But before we dive into that, I just wanted to share that this is really a talk or a discussion on our group as a physician group. And we're an independent physician group, so I'm not here as a health system or as a payer. I'm here really as a physician. And it's really about our physician group thinking deliberately about how we fit into the acute care model in the coming next wave of healthcare. And so this is really a talk about value. It's a talk about tool sets and skill sets and whether we're prepared to really fit in this next wave, and that has a lot to do with this discussion. I have a small, minimal interest in SiriusMD, which has been a good partner for us and is the platform where we do some of this work. So there's our agenda. We're going to talk a little bit about the unscheduled acute care scene. There's some fairly depressing data that we'll start off with. Then we're going to talk about how we're viewing the emergency room visit these days and how it relates to that unscheduled acute care environment. And then we'll look specifically at utilizations and some outcomes. The learning objectives, I think, are available in your app, but there they are. So let me start here. This really is the reality of primary care in North Texas. And I don't mean this in any disparaging way, but primary care has become largely about scheduled care. And so in the last 5 years in Dallas-Fort Worth, the amount of time it takes to get an appointment with a primary care physician has more than doubled. The amount of physicians that are taking Medicaid is down to less than 1 in 4, so it's cut in half in the last 5 years. And so it drives this, and this is national data. In Texas, it's a little bigger than this, but there's just a tremendous amount of unscheduled acute care that's happening in emergency departments. This and even more so for the uninsured population. This is really not news to anybody, but the part that strikes me is that this causes a lot of gnashing of teeth and wringing of hands in the policy gurus and the architects that are really emphasizing getting patients back into medical homes. And I would maybe flip that conversation a little bit and have you think about the ER, quite frankly, is part of the medical home for large percentages of our population. And from a patient-centric view, this is where a lot of folks are going for their care, and it has to do with convenience and availability and the comprehensive nature of it. But we sure are delivering a lot of acute unscheduled care in the ERs these days. If you're a health system, and this is a study out in the last 6 months, very large study looking at the delivery of health care in health systems. So if you're a health system, more than 50% of your visits are coming through the ER. So this is more than your outpatient clinic visits. This is more than your admissions. Your touch points with your patients are really downstairs in that front door of your hospital system. So once you're in the ER and you're there for your acute unscheduled care, what does it look like trying to get back into that scheduled primary care environment? Another study out in the last couple months looking at urgent primary care need following an ER visit and whether you can get in to see your physician or not. And these are the kind of numbers that were being studied in this, or presented in this study. I'll tell you, when this came out in North Texas, these seemed really high to us. The ability to get in within a week, a third of the time, was a little bit surprising to us. And so if you deep dive the study, this is a study done in Connecticut. Connecticut is the luxury of one of the top 20 percentile density of primary care physicians to their population. We're kind of a different story in Texas, near the bottom of the country. And so this probably has a lot to do with why it feels like it's so hard to get into a primary care visit after your ER visit. It's even worse from an outcome standpoint if you have chronic disease. So this is national data, but COPD, diabetes, CHF, all these folks that were really trying to get plugged back into medical homes, making sure they're not coming back in from a utilization standpoint. So a third of those patients following an ER visit have no follow-up visit. And then near and dear to my heart, and this is really what this program is all about, is this maybe not stunning data given what we just showed, but it's a failure rate that is incredible to me, and that is that 8% of patients that have been in an ER are back in an ER in 72 hours. So 1 in 12 of your patients that you see in emergency room are back in the emergency room in 3 days. When you work in the ER, you feel like, no, that's not possible. That many of my patients are not coming back, and that's right, because they're going to the competition across the street a third of the time. So they're unhappy, they're dissatisfied, they move on. But this is 54 million visits, published about a year and a half ago, and this is really a testament to that post-acute ER, or this idea of unscheduled acute care and just really not having a good place to go after an ER visit. Dr. Rising out of Jeff Health has done some research on this phenomenon and interviewed just a ton of these patients and recently published sort of her findings. And I'm sorry about the long quote, but it's very insightful. It really has to do, why do folks come back? And it has to do with anxiety about symptoms. It has to do with not knowing where else to go. And they've lost trust in the healthcare system, ability to meet their needs. And this is sort of what we see every day in the emergency room. So I'm proud of the work that's going on in emergency departments. It's often a disaster situation. I was talking to Eli before this session here. You know, this is an environment where demand frequently, exceeds supply. But there's a lot of heroic work going on. But the reality is a lot of the care that there involves really unreliable transitions to the next step in care. It can be fragmented, and then there's just a tremendous amount of unmet expectation on the part of the patients. As a safety and quality officer for 500 providers, this is what I see in that environment. I see risk, and it's a risk from a safety perspective, from a quality care perspective, and really from experience. So with that doom and gloom, and thinking about where we're heading over the next decade, 5 to 10 years, we sat down about 2 years ago and really thought, how do we fit in? And it really dawned on us that this idea that we were the doctors for 3 hours in the ER just didn't make a lot of sense anymore. And in this environment where folks didn't have any place to go, we thought, what if we could just be the episode of care doctors, the acute care episode doctors? And so when you come into the ER now, instead of this idea of how can I help you, or what brings you to the emergency ward, my favorite is like, what is your emergency? The shaming of the patient for coming to the ER because they have no other place to go. Now, the dialogue and the conversation from a registration, nursing, physician standpoint is really sitting down by the bedside and saying, listen, I'm sorry you're going through this, and we think about emergency medicine a little differently here, and we plan to be with you for a week as you're going through this illness. And we'll be with you, and we'll help you transition, and you can get back in touch with us anytime you need. And so that's the conversation we're starting to have at the bedside now, and I will tell you, it has completely changed the paradigm of thinking among the docs, among the nurses, and it really for just the better. So we launched about a year ago, almost close to a year and a half ago, this effort. It's really a bunch of ER docs that are taking call for themselves. So if you come through one of these participating ERs, at the end of your stay, you get some information on the program. You have 24/7 access back to us. We call it instant care. These are all us, it's physicians, so it's somebody on duty. If I see you in the ER, you may not be interacting with me specifically, but you're interacting with one of my partners who's on shift for that time frame. We all have access to the EMR, we all participate, and a lot of times we involve back in the initial providers in these conversations. We don't charge patients for this. We see this as a value add. It's about us building toolkits and skill sets and sort of understanding what's coming. Our idea was to make this as easy as possible for patients, make it familiar, make it convenient. So we chose a largely text-first flow. We use a platform that's got video capability and audio like most of them do, but we allow people to come in text first. It's of course HIPAA secured. And so this is what it looked like. We started very slow. We had absolutely no idea what demand was going to be. We had no idea what the content was going to be, whether this was going to be a lot of, I need a place to sleep, or my wheelchair's broken, or just kind of really what this was. So we launched in 1 or 2 ERs, watched it for a month or two, and we've been slowly adding on ERs over the course of that year. But we're starting to get some volume and starting to understand it a little bit, and that's why I thought it was worth coming here to talk about. So we're probably closer to 10,000 encounters now, physician-patient encounters in this program. We've maintained a very quick response time, so the asynchronous nature of this thing makes it pretty darn easy to get back right away. So our median response time is about 90 seconds to patients. That's 24/7. A lot of people use this in the week, so we have a tremendous amount of folks that sort of engage, and then either the physician or the patient decides to re-engage, and so we do that over the course of a week as the patients need it. The nature of the encounters has been very interesting to me. We went in this knowing very little about telehealth. We didn't have any strong feelings about text versus video versus audio, or sort of how to do this. We have migrated to largely a text-based system. Incredibly, the encounters last a while, and you see that number, and initially you get sort of nervous. You know, you got doctors spending 40 minutes with a patient. That's the health system doctor view of this thing. If you flip it around and you're a patient, now you've got access. The idea is that doctor spent 40 minutes with me. It's not 40 minutes of my time. I mean, this is 7 to 8. It's 180 seconds of my time. This is 7 to 8 text exchanges generally. Sometimes they're longer, but it's our median, our average number of texts is 7 to 8. But it occurs at the pace that the patient desires. So it's not about me being available for 6 minutes of video and then moving on to the next patient. It really is about maintaining a conversation, allowing mom who's got a wet kid and a dirty dog, or vice versa, to engage at her pace. And then I do this in parallel with multiple patients. So I'm pretty comfortable now in the 6 to 8 patients at a time pace. So we've got multiple conversations going on. This is nothing different than your 13-year-old daughter does every day. It's carrying on multiple conversations. Some of them are fairly intense pace-wise. Some of them are sporadic. But on average, they last about 40 minutes. We see that in the patient testimonials, that it feels very different to the patients. We incredibly stay text-based about 96, 97% of the time. It's very rare that either the patient or the doctor feels the need or desire to go to video. So we largely stay text-based. We occasionally call patients, but it's a very, very small percentage of the time. And then I said most of our doctors are running 4 to 6 encounters at a time. It's a pretty comfort zone. It really depends on how focused the patients are on the conversation. So if they've had to come in and sit down at a laptop and are engaging with you, it can be pretty intense. If they're using the app and they're living their lives, then it's not as intense, and you can handle a lot more encounters at a time. Adoption's been interesting. This is something that we took on ourselves. We have done essentially zero marketing for this. The information about how to sign up for the program sits in the discharge paperwork. We started off with some kind of shiny blue cards and sort of quickly moving to just embed it in their discharge paperwork. If you're around emergency medicine at all, you know that most of those discharge paperwork end up in the trash can in the parking lot. So we get it up onto the first page. And this is the kind of utilization we've seen. Remember, somewhere between 5 to 8% of ER patients are coming back anyway. We find about 3.5 to 4% of patients engage in the service with really a no marketing effect. When you get a motivated ED, when you have a group of nurses and registration and doctors that talk about it, it pretty quickly climbs, and so we have some EDs at the 8 to 10% utilization, so 8 to 10% of their discharges are using the service, but generally it's a little lower. I suspect if you infuse some marketing and a brochure into this thing, that probably more people would use it. This is a pretty common looking distribution of age in the telehealth world, but this is kind of what it looks like. We've had folks out there at the ends of the spectrum. So I had an 86-year-old texting me the other day. I thought for sure it was his daughter, granddaughter. It was the 86-year-old. He actually was offended by the fact that I inquired whether it was him or not. We have a lot of parents that come on for kids. Obviously, we interact with the parents in those situations. Interesting from the emergency medicine perspective, this is the patient satisfaction scores by age group. across the country in ERs. So the millennials are generally fairly dissatisfied with their ER experience. And so we're really tapping into sort of that group that generally is unhappy with the product that we deliver, and we seem to be interacting with a fair amount of those folks, almost inversely. This is what our utilization graph looks like across a day. It's like every other ER in the country. It just starts 3 hours earlier. So instead of the delay it takes to call in work and figure out how you're going to ride to the hospital and showing up at 10, we tend to pick right up at 7 o'clock and stay pretty steady until the late hours. So a few words on outcomes. Excuse me, I think I got the last case of flu in Dallas about 4 days ago, so I'm recovering. But so when we started this thing, we were squarely 100% laser focused on safety, health, and outcomes. And so I, quite frankly, as we launched, didn't think about the other domains of the quadruple aim. We really stood this up with a focus on safety and quality. And I was sort of leading the discussion. Listen, we're not going to correlate this to dollars. This is a value add. And so I was naive. There's always a CFO in the room that wants to talk to you. So, but that's largely how I thought we would be doing this thing and thinking about it. So this is just some early outcomes. We're really now beginning some of our analytics around this. But when we interact with these patients, about 85% of the time we feel like we resolve the issue. And we've now done some deep dives, and when we say we've resolved it, we're finding that most of these people are not back in the ER. So we're finding very few instances where they've interacted with us, told us they were fine, happy, we didn't send them back, and then they're showing back up. Now, they could be going to other systems where we can't see them, of course, but in general, it feels like we're taking care of this about 85% of the time. So in that blue section, there's another 15% that we end up prescribing some additional medicine. So I think about that as treatment failure. So they've come back in, they need something else, and so we're providing some additional therapy in about 15% of those patients. The other 15% are people that their disease has either progressed. We see a lot of embryonic disease in ER, so the appendicitis that starts as kind of vague abdominal pain and becomes appendicitis. So there's just a tremendous amount of early disease in the ER. And so that is the case. Sometimes these folks come on and their story is as scary on the platform as it was 3 days ago to the ER, and you just can't sort of get around the fact that you need to see them again. And so you send them back in. Right now, we're an ED, we're a bunch of ER docs, so we send them back into the ERs. That's where we are, that's where we work, that's where we can see them. As an integrated product into a health system, there would be lots of other options on how you would route these folks, but largely, we send them now to where we are. We do physician-to-physician handoffs, so when folks come back in, it's very much me calling the on-duty doctor, Dr. Smith, Wanda's coming back in, her abdominal pain has gotten worse, she did not get a CT. And then Wanda hears from Dr. Smith and says, hey, I talked to Dr. Muller on the platform, we're really glad you came back in, let's continue your evaluation. So that's the handoff part of that we do back into the hospital. When these people come back in, about 2% of the time, or 2% of the total, so 1 or 7 and 1 of 8 of those folks are actually getting admitted to the hospital. We survey the docs on really what was the encounter about, and again, this is survey data of the physicians at the end of the encounter. So it's as flawed as any survey data, but really what they're saying is about 85% of the time the encounter really was about medical care and advice. There's another smaller percent that come on and have questions about their results or want to know how to get a copy of their CT scan. There's some administrative stuff on here, so work notes and that sort of stuff that we route. And on the platform now we have the ability to route these patients into the care coordination services. So we do have a link. While we haven't developed links into other alternative sites of care, we have developed some links into our social work care coordination support. And so a lot of those folks are routed through the platform into that support service. And then there are some people that just come on and are complaining. And so we feel that some of this, there's a little slice of this that is some service recovery. But most of it, vast majority of it, which makes the work feel good as a physician. Vast majority of this, the docs feel like it's actual medical care they're doing and not some of those other service lines. When we do provide additional therapy on the platform, that's sort of the breakdown of what we're doing. It's not, anytime you do telehealth, particularly post-ER, you worry it's going to become an analgesic service, and it really is not. So 40% of that small slice, so 40% of 15%, so about 7-8% of the time we're doing some additional analgesic. Antiemetics are a big ask on this platform. People give Flagyl and don't add in an antiemetic, and then we do antibiotic switches a fair amount. That's usually about not treatment failure so much as it wasn't on my plan, I couldn't afford it, and there's a fair amount of that. When folks do come back to the ER through this platform, that really is the save. That's the reason we started this program in my mind. And we've had, we're probably over 200 to 300 of those patients now that we've sent back in, and some fairly serious stuff. So this is not just scary stories with, reassuring exams that go back home. This is really early disease that turns into very serious disease, and now we're bringing them back in really a concierge model. So it's staying engaged, it's being there for the patients, bringing them back in a directed, deliberative way, handing them back off to those acute care physicians. From an experience standpoint, we do some surveying of the patients after their encounters, and that's really where all this data comes from. We ask the sort of standard questions. My view is when you exceed expectations, you're going to get pretty good experience data back, and this is sort of what it looks like. So we ask this question of, because of your use of the program, are you more likely to recommend the system? And it's been very, very high, and that makes us feel good. We get lots and lots of these quotes that really, they use the word care a lot and listened a lot, and I think that has a lot to do with this sort of 40 minutes that we give them. They don't feel rushed. They feel like they can engage as they need to, and that tends to show up in their testimonials. Again, we're heading into domains that I never really want to apply to this program, but of course we need to think through it, and so we're starting to do some of those analytics. This is a survey question we ask the patients to say, if you didn't have access to our program, what would you have done? And really large percentage of those folks say they were coming back to the ER. And again, this is, it's survey data. Is it half of this? It may be half, but it's still a fair amount of these folks, and when we've already talked about 8% are coming back anyway, a fair amount of these folks said that they hadn't interacted with us, they were going to come back to the ER. So if you start to plug in this idea of diversion, of saving that extra ER visit, the numbers add up pretty quickly. If you take the number of encounters we had over the year and you start plugging in fair health values for the facility charges and the labs and the radiology and the doctor charges, the number gets pretty big pretty quickly. If you extrapolate that into the number of people that we've offered the service, so not that have used it, but basically the cost savings per discharge in our EDs where we offer the program, we're sort of in this ballpark. And again, this is really a model. So a bit of a stretch, but anytime you talk about ER diversion, you start to talk about pretty significant savings in a hurry. This has been maybe the most surprising part of this whole project to me, and probably the most rewarding. That's the workforce aspects of it. Now I have 40 of my 500 physicians participating on a daily basis with longitudinal or post-ER care. This is sort of the callback program on steroids. And so these are the physicians now that are leading the charge in the hospital-based QA meetings about appropriate antibiotic selection, using antiemetics, the disease that progresses. We've got physicians that are really bought in now and thinking about episodes of care and not just sort of that run-in-the-mill there in the ER, seeing people 3 hours at a time, and it is infectious. It has really changed the dialogue at the QA meetings, and for me, probably the most rewarding aspect of this program. And there's lots of examples of that. I know this is too small to read, but this was a patient that was seen by the president of our company. She was septic, urinary sepsis, single mother of 3, chose to go home because she didn't want to deal with the hospital costs. And she came back on basically unprompted on the platform the next day and said, I just want to let you know I feel a lot better. And and interacting with him in that manner, that floated his sales for like a month. I mean, talk about a fix for burnout. So that was just one example of many where the doctors have really had some pretty rewarding experiences on the platform. This was a quote we got on one of our testimonials, and so it was awful fun to send this back to the doctor. So much for HIPAA stuff here, but these sorts of quotes that come back to you make you feel really good as a provider. ICUs, ERs, you just don't get a tremendous amount of patient thanks in those settings, and so this has really tapped into a whole sort of different aspect of that for us. So I think we probably are touching all aspects of that quadruple aim. I didn't think about that in advance, but it feels like we're starting to sort of generate real impact in all of these important domains. So let me just close. I'm at HIMSS. There's a lot of IT emphasis here. So of course, it dawns on me as a physician that is affiliated with some health systems and now is in the room talking to them about their IT that largely patients want to get care from their portals, from their systems, and so my filter on a lot of this these days, as I think about what we're going to put up on a portal next or what the app is going to do next, really has to do with what does it deliver to the patient, and looking up your CBC or parking maps. It's helpful, but it's not what patients need. And so using this technology to make care accessible, I think, is the litmus test in my mind for most of these technologies. And then along the same lines, if you're going to invest, I think investing is about building trust with patients, it's about strengthening relations with patients, and that's where I would be sure putting my dollars these days. All right, that's all I had, Eli. Do you want to see if there are any questions or...